My name is Kendall Shibuya, and I'm going to be talking about benzodiazepine tapers in primary care. So to get us started, we're going to the objectives. Oops, that's not looking that way. The objectives of our talk is to, still not moving. There we go. To review safe approaches to benzodiazepine tapers and to describe adjunctive interventions to facilitate a successful taper. And to kind of frame this talk, I'd like to share one of my patients who has taught me a lot about benzodiazepines over the last couple of years. But before I kind of go into detail about that, I want you to think about any patients that are maybe on your panel who's currently using benzodiazepines, or maybe you have some, maybe you don't have any because you've already been doing a lot of this work already. So with that person in mind, kind of think about how those visits make you feel, and when you're thinking about those visits. For me, I often feel a little bit overwhelmed. I feel a little bit defeated because I've been working on this taper with them for a long time. And sometimes it just feels like each visit is a little bit like I'm going into crisis mode, and I don't know exactly or crisis mode for that patient, and don't know where to go. So I'm hoping that this talk will help alleviate some of those fears or those feelings that we all maybe sometimes feel. So this, I'll say she's my teacher, is a 61-year-old female. Her past medical history is pretty significant. She has COPD, severe stage, hypertension, opiate use disorder, currently on Suboxone, benzodiazepine use disorder, depression, anxiety, PTSD, insomnia, Barrett's esophagus, hepatitis C, status post-treatment, obesity, and osteoarthritis in her knees bilaterally. A little bit more about her opiate use disorder. She has a history of heroin use, and she last used in 2013. Initially, she was on methadone and then underwent buprenorphine and naloxone induction in January 2018, and has been stable on 16 milligrams daily since then. And a little bit more about her benzodiazepine use disorder. She's had a history of benzodiazepine use intermittently since 2000. She's used mostly clonazepam and alprazolam. And at the time in 2019, when this taper was started, she was using alprazolam, Xanax, 4 to 6 milligrams daily. So when hearing that case presentation, probably a few different red flags went off in your mind, and we'll kind of go through these stepwise throughout this presentation. To start, before going into detail about taper, we'll talk a little bit do a brief overview about benzodiazepines and what they're indicated for, the different types of benzodiazepines and the dose equivalents. So there are some indications for benzodiazepine use. It's used for anxiety in the short term, pre-procedural panic disorders, acute anxiety, insomnia, also emphasis on the short-term use, muscle relaxants, which you've seen used maybe in the ED sometimes, anesthesia, alcohol withdrawal, seizures, and palliative care. And although current guidelines suggest short-term use, long-term use is common, which is why we often see these patients on our panels. So briefly, let's just review some of the types of benzodiazepines. There are short-acting, intermediate-acting, and long-acting. And the short-acting, like midazolam or Versed, is often used for sedation. And then the long-acting, like chlordiazepoxide and diazepam, are often seen in the setting of alcohol withdrawal treatment. And then the intermediate acting are like alprazolam or Xanax or clonazepam, Klonopin are often used in the outpatient setting, or those maybe are medications that they're purchasing in the community illicitly. So our patient was using alprazolam and clonazepam. And when thinking about benzodiazepines, it's sometimes helpful to be able to compare them and know the dose equivalents. So lorazepam, 1 milligram, is about 0.5 milligrams for alprazolam, and the clonazepam conversion is kind of a range. So for our patient, she was using alprazolam or Xanax 6 milligrams daily, or 3 Xanax bars, and then that converts to Ativan or lorazepam 12 milligrams daily, and clonazepam 3 to 6 milligrams, which is very high doses for these. So why is it important to try to taper or deprescribe benzodiazepines? And I think we're all familiar with the risks related to this, but kind of to frame it, I think thinking about the prescribing trends really emphasizes why this is important. And this quote by the Tannenbaum et al., I think summarizes it well. Benzodiazepines comprise 20 to 25% of inappropriate prescriptions in the elderly, with reported prevalence of use ranging from 5 to 32% in community dwelling older adults. Although physicians recognize the risks associated with benzodiazepines, almost 50% continue to renew prescriptions, citing patient dependence and benefits as justification for their actions. And then Olfson et al. Also note that this trend increases with age, And they found that the percentage of benzodiazepine use in general, and particularly long-term use, increased with age, and that a large percentage of these prescriptions were coming from primary care. So it's something we'll encounter a lot. And for this reason, there's been a huge push to really provide more support and evidence for why we need to do this deprescribing. And the American Geriatric Society teamed up with the Choosing Wisely campaign to come up with the top 10 things that physicians should focus on. And number 4 on that list is trying to get them off of benzodiazepine or benzodiazepine receptor agonists. And this is because there's a whole host of adverse effects that we all are aware of: dependence, abuse, adverse central nervous system effects, dementia and cognitive decline, falls and fracture risks, motor vehicle crashes, and increased mortality overall. And then, as you all are also aware of, there's a black box warning on benzodiazepines now, discussing the risk for concomitant use with opiates, the risk for abuse and misuse and addiction, and then particularly also the risk for dependence and withdrawal reactions, which we'll talk about more throughout this talk. So you know that you want to taper your patient now off of benzodiazepines. What are some of the things that you need to keep in mind? And these are probably things that your patient is already well aware of, which is also contributing to their hesitancy for wanting to engage in this discussion about tapering off of this medication. So some of the red flag symptoms are those severe reactions to stopping this medication. Is when you abruptly discontinue it, it can induce seizures and delirium tremens, and this is something that can be fatal. It can lead to autonomic instability with increased heart rate and blood pressure and tremulousness and diaphoresis. And these severe withdrawal symptoms are something I think a lot of us are aware of, but it is something that's pretty rare, and it happens really when you're on high doses and do not taper. It's rare for it to happen when you're doing a controlled taper. I think the other ones, we'll call these the yellow flags, are the withdrawal symptoms that people experience even as they're decreasing their dose. The symptoms are physical and psychological symptoms, and they kind of mirror the symptoms that maybe they were started on this medication for, like anxiety and insomnia. It's experienced by a large percentage of patients. 35 to 45% of patients will experience these withdrawal symptoms. And for shorter acting benzodiazepines, it'll appear 1 to 2 days, and then longer acting, it'll be 7 to 8 days. For longer acting agents. And then 15% of these patients experience withdrawal, who experience withdrawal will have protracted symptoms that will last months to years. Okay, so we really know that we want to taper our patients, but we've had this discussion, they're really hesitant. How can we help set ourselves up for success to engage in this taper discussion and help get them set up for it? This is a great excerpt from the Clinical Practice Guidelines in the Canadian Family Physician Journal that's saying, how do I start this conversation? And from their research, they found that patients have really indicated that they're more amenable to this discussion of deprescribing if there's a clear plan. The rationale for deprescribing is clearly explained. And then if there's kind of the motivational interviewing component, like meeting them where they're at, where you can kind of negotiate that and really highlighting the risks that we've just covered, and that the therapeutic effect of benzodiazepine receptor agonists is often lost within the 4 weeks, owing to the receptor changes that they experience. And then there are mild short-term, and really kind of doing that anticipatory guidance about the withdrawal effects during tapering. So what are these steps that we can do that? And I think it kind of is nice to break it down into 4 steps that we'll walk through today. So first, we're going to be screening our patients for the benzodiazepine use disorder and comorbidities. We'll be educating our patients about the risks of benzodiazepines, and I'm going to highlight a lot of really helpful resources for this. Provide anticipatory guidance about withdrawal symptoms, and then engage in creating a taper plan using motivational interviewing. So to start screening our patient, one is screening for appropriate use. Is this within that short-term window? Are they getting any side effects? Do they still have a clinical need for it? And then screening for what is high risk for a difficult taper. Previous failed attempts, comorbid chronic psychiatric illnesses, personality disorders, history of other substance use, lack of support, older age, and high dose. High dose being greater than 60 milligrams of diazepam, which is, just to put that into context, 6 milligrams of alprazolam, which our patient is on, is about 90 milligrams of diazepam, so a very high dose. And then also a tool that can be used is the severity and dependence scale, which we'll walk through. So to revisit our case, she was using benzos to help with sleep and anxiety, and this was a long-term prescription for her. So red flag there. She has a history of substance use, and then she had been buying benzodiazepines illicitly in the community. Another red flag there. She had previously weaned herself off of benzodiazepines and had successfully tapered with medical management before. but she's using again. So we'll say that's maybe a yellow flag. She has some psych comorbidities of depression, anxiety, and PTSD, another red flag there, and older age. We should probably put there also the high dose. The severity of dependence scale tool that I mentioned is something that could be handed to patients similar to like a PHQ-9 or GAD-7, where it's a self-assessment tool. So walking through with our patient, if number one, do you think of your use of the benzodiazepine was out of control? Probably select often. Did the prospect of missing a dose make you anxious or worried? Always. Did you worry about your use of the drug? Sometimes, often. Did you wish you could stop? Often. And how difficult would you find it to stop or go without the drug? Impossible. So her score is high at 12. And this is a good screening tool along with assessing for those risk factors of thinking, is this somebody who I could potentially taper in my clinic in the outpatient setting? Or is this somebody who's going to need a lot more wraparound support, is maybe at high risk and needs to be in a specific treatment center or in the inpatient setting? Step number two is something you can do also while you're screening and throughout the process. This is kind of like the emphasis of primary care is patient education all the time, but education about the risks. There's this fabulous trial called the Empower trial. They came up with a great acronym for their trial. It stands for Eliminating Medications Through Patient Ownership of End Results. And this trial, they provided the patients with a pamphlet that went through the importance of deprescribing benzodiazepines. And this wasn't even in the clinic setting. This is something that was just mailed out to patients. And 62% of patients who received that initiated conversation about taper, and 27% of that group discontinued by 6 months. That's compared to 5% in the control group. So just by providing patients with that information, it was a successful intervention. And then really having a lot of discussions about providing anticipatory guidance about withdrawal symptoms so that they know kind of what is a withdrawal symptom and the timeline for that versus what is kind of a recurrence of their previous symptoms and how we can manage it with alternative strategies. Approaching those conversations, this is where I often would feel overwhelmed, is like, how do I have this conversation? And some of that is knowing what resources you have. And I don't know exactly why Canada has all these fabulous resources, but they have a ton of fabulous resources related to this. And one is through the Center for Effective Care in Canada. And I just provided all the links here. And the other is the deprescribing.org, which you're probably familiar with. So this is just a picture. And basically, this is like a wonderful 12-page PDF that summarizes everything I'm talking about in a much more concise and easy to access way. So you just do yourself a favor and download this. It's very helpful. And then the deprescribing.org has a nice like 2-page PDF that helps walk through it. And sometimes nice to help yourself prepare, but it's something you could also like walk through with the patients because then they know kind of why you're approaching it the way that you are. So that is that. And it also, this is on the back side of that, it provides information about tapering dosages, but also the behavioral adjuncts that you can use. I think the other part about education is patient resources. So not only do the providers need to feel prepared for the discussion, but also having resources to share with the patients. So this is patient-facing resources. One is from that Empower trial. It's the pamphlet that they used in that trial, and it's a free resource online that you can download. I think it's about 8 pages. And then the deprescribing.org also has some great patient-facing material. And this is the patient brochure that was used in the Empower trial, and it talks about like listing the medications, kind of doing a quiz of their understanding of why they're on this medication and what the potential risks are, and then outlining in a nice, clear way the risks of it and presenting a potential taper program. And you can see that this taper program, even though it's a nice picture, it is kind of complicated because there's a lot of different doses that you're doing each day, and just kind of having a context for why you're doing it is helpful to definitely work with the provider. Here's just another example of some of the other patient-facing materials through deprescribing.org, and they're just really nice, clear, like 1-page things that you can provide patients. And it could be something like visit 1, you're talking about this, providing them with this resources, and at a follow-up, you talk more about the taper plan. And throughout all this, you can also be doing the anticipatory guidance. And I think this quote from the Cochrane Review of Deprescribing Benzodiazepines that was published in 2018 summarizes the importance of anticipatory guidance really well. It says, withdrawal symptoms may manifest both physically in flu-like symptoms, muscle cramps, and psychologically with irritability, insomnia, perceptual changes, anxiety, and depersonalization, derealization. And then withdrawal symptoms, therefore, often resemble the symptoms that led to the initial benzodiazepine prescription, erroneously leading patients and caregivers to assume that continued prescription is required. So discontinuation is thus complicated by a mixture of withdrawal symptoms and original symptoms that might reoccur in an exaggerated form, the rebound symptoms. And then step 4 is creating the taper plan, which we'll go into more detail. Kind of briefly, there's really no universal taper plan, and this is where that motivational interviewing and working with your patient to see what's going to work with them and their lifestyle will really be helpful. And you can see this table to the right is just of the various systematic reviews that have looked at different taper plans, and they range from going like 5% each week to 25%. So there's a lot of variation with that. And then motivational interviewing tools, which you are all familiar with already, but really resisting kind of telling them what you're going to be doing and working with them to figure out what will work with the patient. Okay, so we've laid our groundwork for doing the taper. Now, how are we actually going to taper them, and what are some of the key points of this? And there's 2 main points: is the rate of discontinuation, and then also what other medications or behavioral adjuncts we can provide for the patients. So for the rate of discontinuation, like we talked about, there's really not a set prescribed taper that you'll use. It ranges 8 to 12 weeks to years, 1 to 2 years or more. Expert opinion is that you should decrease the dose by 10 to 25% every 1 to 2 weeks. And that with this approach, 60% will be benzodiazepine free with this approach. Sometimes they're recommending a longer taper. So in that Empower trial with Tannenbaum et al., they did a 22-week taper protocol that they found success with. And then this one really stuck home with me. For complex cases, you may need to stabilize dose at 50% reduction for several months before resuming the taper. And at the end, sometimes patients may need homeopathic dosage reductions to tolerate withdrawal. So it can be very prolonged. And in the Cochrane review, they highlighted that the individually adjusted withdrawal rate should include consideration of the benzodiazepine type and dosage, original reason for prescribing, environmental stressors, and the amount of available support that the patient has. And that the duration of tapering is thus sometimes prolonged for months or years. However, very slow tapering regimens do not seem superior to faster tapering regimens, which is kind of the tricky part here. So this is the example of the 22-week taper that the Empower trial used. And you can see how they're using 1 to 2 quarters of a pill kind of in the last weeks 17 to 22. So it's really spaced out there. So the pharmacologic approaches, there's a couple different ideas for this. There's one of using the same medication that the patient is already on for the taper. And then there's been the thought process of potentially switching to a longer acting benzodiazepine at the beginning of the taper. And this, in the Cochrane review of 2006, through the systematic reviews, they didn't find that this was supported by the evidence to switch to a longer acting benzodiazepine. There's also the idea of using other medications to help with the withdrawal symptoms. And in the Cochrane review in 2018, overall evidence for this was pretty low or very low due to the small number of trials and the limited number of participants. But they found some potentially positive effects for the following medications. In these classes, the anticonvulsant, antidepressant, and GABA receptor antagonist classes, and then kind of specifically for symptomatic treatment for headaches and diarrhea and nausea, vomiting, using those medications. And this table, published by the Kaiser guideline about deprescribing, kind of goes specifically about those medications and what doses to use. But again, there's not strong evidence for this. And that's similar to that CEP. This is taken from that 12-page PDF that I referenced earlier, kind of outlines how you could use these adjunctive medications to help with the withdrawal symptoms. But really, there's no significant evidence to support this. And it's really something that you'll discuss with your patients about. And I think it's often something we may end up doing because the patients will be very hesitant about taper because of the symptoms they may experience. So being able to offer something else for support will be helpful. There's more evidence for a lot of the behavioral adjuncts, particularly the psychological interventions, relaxation training, psychoeducation for helping with management of rebound symptoms. And they're superior to doing a gradual dose reduction alone in primary care settings. So to help just wrap up the case now, our patient weaned herself down from the alprazolam 6 milligrams daily to 3 milligrams daily. And then she was transitioned in our clinic to clonazepam 1 milligram daily for a 1-week taper. And this was too fast and wasn't tolerated by the patient because that was a really fast taper. Then it was adjusted to trying to do a 2-week and 6-week taper, which also had some failed attempts. So we had her, just as a reminder here, for that switch from alprazolam to clonazepam. So she was using about 3 milligrams of alprazolam. Switching it to clonazepam is like 1 to 3 milligrams. So switching her to 1 was in that lower conversion dose. Although there isn't evidence for switching to longer acting benzodiazepines, and this is still within the intermediate acting, it's just a longer acting in the intermediate class with that 30-hour half-life compared to 11.2-hour half-life. There is some thought process that using longer acting benzodiazepines offer advantages with having potentially fewer rebound symptoms, but there still needs more research in that area. So we are fortunate we have a psychiatrist here that we do psych co-visits with, and she helped us create and kind of recreate this taper over and over. But for the first psych co-visit in 2019, the plan was to restart the taper at clonazepam 1.5 milligrams daily, and then created this 7-month taper plan that you see below, which is kind of, you can see for the first 3 months doing that about 20% taper per month, not even per week, per month. And then she is here at month 4, about 2 years later. COVID had something to do with that because her support system really disintegrated during that time, but it's been very, very difficult. And we've attempted to use CBT as adjunct, and it's been hard to set that up for her. And then using other medications hasn't worked well for her for the adjunct pharmacologic therapy. So from this, I've learned these few conclusions: that benzodiazepines can be dangerous, particularly the elderly, with increased risk of falls and decreased cognition and decreased overall mortality. And that tapers are hard, very hard. And that, some of it is that you really need that benzos are addictive and that their withdrawal side effects amplify the symptom that they were often started for. So really that reinforces the feeling of dependence, and that counseling on that is really important. So patient education and anticipatory guidance is very important. And that while it is important for us to do this in the outpatient setting, not all patients are appropriate for the outpatient setting. So I think really screening your patients for those psych comorbidities and the histories of substance use and prior attempts is really important, and getting them connected with the appropriate therapy is important. And here are my references.
Place benzos for sleep or anxiety in our elderly patients. Hard to find medications that are as effective and always risk for side effects.
Yeah, that's a great question. And I think everybody is still kind of looking for that magic answer, because a lot of the ones that are oftentimes recommended, like gabapentin or some of the other ones, they also are on the Beers list and have other side effects. So I'm sorry, I don't have the answer for that, but I would love to know if somebody else has the answer that wants to add to the chat. Doxepin, as our Jerry fellow says.
Can you comment on safety of prescribing benzos as a taper? I worry that patients will sell or combine with street drugs.
I'm wondering if this is in relation to to kind of taking over a benzodiazepine use that was initially used when they're purchasing it illicitly in the community, and then taking over that taper. And that is something that I was looking for evidence for. There's not a lot in the literature for taking over kind of illicit use and taking over it to do a medically supervised taper. And I think for a lot of those patients, doing that in the outpatient setting when they have been using it illicitly or they are using other substance use, it's something I probably will not do again and don't necessarily recommend, because it's really hard to do in the outpatient setting, and they would be better served in a treatment center.